So here we have a patent ductus arteriosus. In fetal period, your shunt is right to left. Okay, that's normal. In neonatal period, you have a reduction of your pulmonary vascular resistance. You have a shunt becomes left to right. Progressive right valve and left ventricle, right ventricle and left ventricle, and heart failure. Associated with a continuous machine-like murmur. Patency is maintained by PGA synthesis and low oxygen tension. Uncorrected PDA can eventually result in late cyanosis in the lower extremities. Okay. Endomethacin ends patency of PDA. PGE will keep ductus going, may be necessary to sustain life in conditions such as transposition and great vessels. PDA is normal in utero and normally closes only after birth. Uncorrected left to right shunt like VSD, ASD, PDA, again will increase pulmonary blood flow. And therefore pathologic remodeling of vasculature, pulmonary arterial hypertension, and then shunt becomes right to left, causes late cyanosis and clubbing. Remember, clubbing is when you have your fingers, they protrude outward at the tips, enlarged phalanges, and then polycythemia, different age groups onset. You also might have coarctation of the aorta. So the aorta kind of collapses in itself, it folds inside of itself. Aortic narrowing near insertion of the ductus arteriosus, juxtaductal, associated with bicuspid aortic valve, other heart defects, and Turner syndrome. Hypertension is upper extremities and weak, delayed pulse in lower extremities. Brachiofemoral delay. So I know there's test questions that deal with that. If you have femoral delays, pulse slow in your legs. With age, intercostal arteries enlarge due to collateral circulation. Arteries erode ribs. You'll have a notched appearance. Okay? And complications include heart failure, increased risk of cerebral hemorrhage, aneurysms, and then aortic ruptures, possible endocarditis. Congenital cardiac defect associations, alcohol exposure in utero. So don't drink during pregnancy. You'll have fetal alcohol syndrome. Possibilities of defect, VSD, PDA, ASD, and tetralogy of Fallot. Congenital rubella, PDA, pulmonary artery stenosis, and septal defects. Down syndrome, AV septic defect, endocardial cushion defect, and VSD, ASD. Infant of diabetic mother, transposition of great vessels, VSD. Mixing of the great vessels, I guess, aorta, pulmonary artery. Marfan syndrome, popular syndrome. MVP, thoracic, aortic aneurysm and dissection, aortic regurgitation. Prenatal lithium exposure, Epstein anomaly, lithium, Epstein. Turner, bicuspid aortic valve, coarctation of aorta. Williams syndrome, supravalvular aortic stenosis. 22q11 syndrome, that's a gene, I believe, and truncus arteriosus, tetralogy of Fallot. Hypertension, defined as persistent systolic blood pressure of more than 140, and diastolic blood pressure greater than 90. Risk factors, increase of age, obesity, diabetes, physical inactivity, excess salt intake, excess alcohol, cigarettes, family, congenital, African Americans, highest rate, I think it's 70%. Caucasians are 30, Asian is 12, plus or minus. Features, 90% of hypertension is primary, can be related to cardiac output increase. Remaining 10% mostly secondary. Fibromuscular dysplasia, string of beads appearance of renal artery. Atherosclerosis renal artery, stenosis or to primary hyperaldosteronism. Hypertensive urgency, severe is anything over 180, 120. Hypertension without acute end organ damage. Hypertensive emergency, severe hypertension with evidence of acute end organ damage. Encephalopathy, stroke, retinal hemorrhaging, exudates, papilledemia, MI, MHF, aortic, kidney, microangiopathic, anemia, eclampsia, CAD, LVH, HF, atrial fibrillation predisposes, aortic dissection, aortic aneurysm, stroke, chronic kidney disease, retinopathy, hypertensive neuropathy. So all of those predispose. Hyperlipidemia signs, xanthomas, plaques or nodules composed of lipid-laden histiocytes in your skin. That's your A. Right here. Tendinous xanthoma, lipid deposits in your tendon. Right here. That's your knuckles, it looks like. Achilles as well. Corneal arcus, lipid deposits in your cornea. Common in elderly arcus senilis, but appears earlier in life with hypocholesterolemia. Good long words. Atherosclerosis, hardening of your arteries with arterial wall thickening and loss of elasticity. Common arteriosclerosis affects small arteries, arterioles. Hyaline, which is thickening of the vessel walls, and essential hypertension, diabetes mellitus. That's A. That's right here. And hyperplastic, onion skinning, and severe hypertension. That's B. With proliferation of smooth muscle cells. Monkenberg sclerosis, medial calcific sclerosis. Right here. Very uncommon, affects medium-sized arteries, calcification of internal elastic lamina and media of arteries. Vascular stiffening without obstruction. Pipestem appearance on X-ray. Does not obstruct blood flow. So these are the arteries that go down. See? All right. Then you have atherosclerosis, very common. Disease of elastic arteries, large, medium-sized muscular arteries, form of arteriosclerosis caused by buildup of cholesterol plaques. You might have abdominal aorta, coronary artery, popliteal artery, and a carotid artery. There you go. After I work out my abs, I grab a Corona and pop my collar up to my carotid. These are your locations. Risk factors: modifiable smoking, hypertension, dyslipidemia. Low density lipids, high density lipids. Diabetes, non-modifiable. Age, sex, increase in men, family history. Symptoms: angina, claudication, can be asymptomatic, progression, inflammation, important in pathogenesis, endothelial cell dysfunction, macrophage and low density lipids accumulation, foam cell, so that's when their LDLs are the bad cholesterol if it gets high, fatty streaks, smooth muscles, cell migration, proliferation, extracurricular, extracellular matrix, fibrous plaque, complex atheromas. There you go. Complications, aneurysms, ischemia, infarcts, peripheral vascular disease, thrombus, and emboli. Aortic aneurysm. You have a localized pathology of aorta, dilation of your aorta. May cause abdominal back pain, leaking, dissection, imminent ruptures. Might have abdominal aortic aneurysm. This is associated with atherosclerosis. Risk factors include history of tobacco, increase in age, male, family history. May present as palpable pulsatile abdominal masses, most often infrarenal, distal to the origin of the renal arteries. You might have thoracic aortic aneurysm. Associated with the cystic medial degeneration, risk factors include hypertension, bicuspid aortic, connective tissue disease like Marfan, third-degree syphilis, obliterative endocarditis of the vasa vasorum, aortic room dilatation may lead to aortic valve regurgitation, and then traumatic aortic rupture due to trauma, deceleration injury, most commonly at aortic isthmus, proximal descending aorta just distal to the origin of the left subclavian artery. Okay. Aortic dissection, so dissect is tearing away. Longitudinal intimate tear, forming a false lumen or opening. Associated with hypertension, bicuspid aortic valve, inherited connective tissue disorders, Marfan. Can present with tearing, sudden onset to chest pain, radiating in the back, unequal blood pressure in your arms, mediastinal widening can result, so basically your ribs can result in organ ischemia, aortic rupture, death. Stanford A, proximal, so close, involves ascending aorta, make sure you know that, A to A. May extend to the aortic arch or descending aorta, but they're proximal. May result in acute aortic regurgitation or cardiac tamponade. Surgery is needed. Stanford type B, these are distal, farther away, involves only descending artery, aorta, below the ligamentum arteriosum. Treat medically with beta blockers and then vasodilators.